As clinicians, we're very interested in relieving symptoms. So we have a focus that looks very much at benefits. When we see people improve, these benefits we ascribe to what we've been doing. And in a holistic fashion, that is correct. But in a specific fashion, with respect to particular medications, say, that may not be quite so accurate. So if we see a improvement in half of the people we're treating, we could construe that to be that, so medication X is causing this improvement. But there are a lot of non-specific factors like positive life events or time passing or paying attention to diet and exercise, psychotherapy that's going on concurrently with the medicines that could account for improvement. This is the reason we see placebo responses in patients who have bipolar disorders and other affective disorders. These placebo responses are something that's actually valuable to clinicians, and it's useful. We're using everything we have to try to help people, but they can confound our ability to be able to identify specific benefits of specific medicines. So if a medicine has a response rate of 50% and placebo has 25%, then we may think that we're doing about twice as well as we are really doing with a particular medicine. The same holds for harms. And so harms can occur that are specifically in relationship to medicine, but harms can occur for other reasons, such as negative life events or medical occurrences or depression itself, say, making people sleepy. And so consumers are very, very concerned about harms, and they may ascribe all harms, including non-specific harms, to the intervention. So with respect to specific medication interventions, we have a situation where clinicians are therapeutic optimists and consumers are side effects pessimists. And certainly for the therapeutic alliance, it's necessary for each of these parties to be mindful of the mindset of the other. So particularly with providers, if we can pay an adequate amount of attention to both benefits and harms, we can probably bring more added value to the therapeutic alliance. And there are ways of doing this. There's mathematical formulas, things like number needed to treat, number needed to harm, that can be used. And really doing a specific accounting of possible benefits and harms that are in relationship to the intervention you're going to do and not just general is an important approach to treatment. And so in the treatment of bipolar disorder, we are as likely with the approved treatments, which at this time are quetiapine and olanzapine fluoxetine combination, we're as likely to cause benefit as harm. Okay, and the harms that we get are, say, weight gain with olanzapine fluoxetine combination and sedation with quetiapine. And so we're in the same ballpark. And this may be a challenge for patients and providers. Now, if somebody has severe insomnia and they're way underweight, then these potential harms are not such a big deal. But say somebody is already sleeping too much and already weighs too much, then interventions that cause either sedation or weight gain are not a particularly good idea for that person. So the key element to this is to be sensitive to both benefits and harms and to individualize that assessment of benefits and harms to the patient's individual circumstances.